Next, I'm delighted to introduce you to Professor Emer Joyce, Consultant Cardiologist from the Mater Hospital in Dublin, and Professor Joyce's presentation is on ATTR amyloidosis and the heart. Professor Joyce.
All right, so we're almost there. I think this is the penultimate talk, the appetizers to Professor Gilmore coming up. But that was phenomenal, Sinead, and right back at you in terms of thanks. I want to say thank you to Rosaline, Jim, Paddy, all the organisation. I told you last night, I said Simon Coveney needs to know about this. Stormont, Westminster, Brussels, Dublin. I think everyone could learn from this amazing model of how to get things done. So huge kudos, and really looking forward to working with you in the future. This is my only squeamish picture. I'm sorry, I thought I'd gone through in detail to take any sort of potentially post-lunch squeamish pictures out. But I'm going to speak today about amyloidosis, ATTR specifically, and the heart. I'll probably bring a little bit more of wild type into the discussion, but in a lot of cases combine both hereditary and wild type in terms of the phenotype of what we see with cardiac disease. This is an example of a heart which, I guess to use a Galway term, is riddled with amyloid in terms of really thick heart muscle. And what we're really working on, what we're so excited about, is bringing this disease so much earlier and not getting to the stage where we're seeing these significant heart manifestations. So we're only moving forward with this disease. So I thought it was really nice to sort of look back and go back into the history books, and I found it was 1949 when Dallin first described cardiac amyloid at an autopsy. So of course it's taken nearly 70 years to get there in terms of specific treatments, both for amyloid associated with polyneuropathy and cardiomyopathy and the various treatments there. But hopefully in a lot less than 70 years we're going to see further amazing advances. So a question I get asked a lot, again, probably coming more from a wild type background here, is, where has this been? Is this new? Is this a new epidemic? And I think there's a couple of factors that are all coming together in a good way to bring us where we are here today and where we're going to go forward in the future. There's certainly increased awareness. We're looking for it more. We're looking for it more as cardiologists, as GPs, as internal medicine physicians, neurologists. It's also much easier to find it now when we do go looking for it. It means a lot more to find it. I'm old enough to remember, back in the day when I was training in cardiology, we'd see what we'd say would be a funny echo or a speckled echo. We sort of said, oh, that's probably that amyloidosis thing, but we didn't really have any treatments apart from, I'm going to go through some general cardiac treatments that we have. But it means so much more to find it, and I loved Mary's statement of, we just cannot accept no diagnosis anymore. We really have to diagnose each and every case, number one, and as early as possible. So it's a real call. That would be my one message, I think, taking from Mary at the meeting. One of the things that I think is a challenge and an opportunity, is there a true increased prevalence? Speaking particularly about wild type here, is it, we know there's a link with aging. I think there's a lot more to be explored here. I think epigenetics probably comes into it. There's a whole other piece and focus and challenge and opportunity in terms of rediscovering, is there an increased prevalence, and if so, the true picture of why. So the outline of the talk today, I'm going to talk briefly about how exactly it affects the heart. I want to talk about how people might present to me specifically in the cardiac clinic. We'll talk briefly about what exactly the tests are when you come to the so-called amyloid heart clinic. How do we diagnose it and how do we monitor it? I'm going to talk a little bit how we treat the heart manifestations that are not the disease-modifying therapies that you're going to hear about after. And we'll briefly talk about, remove some of the mystery about what happens at the amyloid and heart failure clinic, which I'm going to talk about now. When we talk about cardiac effects of heart effects of ATTR amyloidosis, I think of them in three big buckets. First of all, the amyloid fibrils are how they affect the muscle. So as we've heard, they're going to infiltrate the muscle of the heart. Heart muscle myocytes are very, very biased, but they're very specialized. They've a lot of good work to do. They do not want a sticky protein that is interrupting their pump function. So one of the biggest things that we worry about, that we want to try and prevent, is cardiomyopathy, and that's Latin for a sick heart muscle. And that predisposes to the term heart failure, which is in inverted commas, because we're going to talk about that term in a minute. Atrial arrhythmias, you've probably heard us mention AFib, atrial tachy, aflutter. And they're a very, very common and often quite vexing manifestation of ATTR amyloidosis. About 70% of our wild-type patients will have AFib. Probably 40 to 50% of our hereditary ATTR patients will have AFib, or otherwise known as a fast irregular heartbeat. So we might talk briefly about how we might treat that and recognise it. Conduction system disease is otherwise known as a slow heartbeat. And again, just as I said, those heart myocytes are very important at squeezing and providing the pump function of the heart, the electrical cables also go down through that septum, through that mid-region, and having a protein in the middle to sort of interrupt or short circuit that cable can often have people present with slow heartbeats, with passing out, which we call syncope, or near passing out pre-syncope. So they're the three big things that sort of, when you're coming to an amyloid clinic, that as a heart doctor I'm thinking of looking for, screening for, and or treating these big, kind of three big buckets of manifestations. I want to stop here by saying heart failure is an absolutely terrible term. I hate calling myself a failure doctor. I'm not a failure doctor. I'm hopefully a success doctor. But, if I was in the States, we're really moving towards calling ourselves heart function cardiologists. And I think you'd all prefer if you were coming to the heart function clinic, right? Even the heart dysfunction. The kidney doctors do this much better than us. I think they used to call it, renal insufficiency or renal inefficiency. And I think we need to get better at calling it either heart dysfunction or heart inefficiency. And I think it's also easier to explain it, because when I say, look, I'm going to ask you to do these huge amount of things, take this huge bucket of pills, restrict your fluid and your salt, stop drinking alcohol, have a healthy diet, have a healthy weight. It's a lot of stuff. But if I tell somebody that, look, it's all about getting that heart back to efficiency, I think it's a good sort of way to think about it, rather than, oh, sure, my heart's failing anyway. May as well just go out and have the few pints, right? So it's just about reframing it. So it does not mean that your heart has stopped working. It isn't doing exactly what your body needs. It isn't able to do it. And in this case, in amyloid, it's really because that pump function is restricted. So what type of heart failure does amyloid cause? There are a myriad causes of heart failure. There are myriad causes of heart dysfunction. And I should say that often patients who get amyloid, whether hereditary or TTR, are further along in life or older in life. So there often are coexistent causes. I'm going to talk a little bit about blood pressure in a minute. Also, coronary artery disease, more sort of what you might say the garden variety heart causes. So we always have to look for those as well. And they might be sort of co-located in as well. And we have to bear them in mind. But the classic, these are a couple of pictures that I took on holidays, and I realized, God, I really need to get more time off if I'm seeing HFpEF in a rock and I'm seeing HFrEF in a this is a Gaudi thing in Barcelona, I think. But I thought it was a good, let me know, I thought it was a good descriptor. So when we talk about amyloid, we talk really about this stiff or thickened heart. And it's sometimes hard to explain, why is somebody getting sort of heart failure, heart dysfunction if their pump is normal? Well, the heart doesn't just pump, it pumps and it relaxes, and it really needs that relax phase to fill with the blood to get ready for the next pump. So even if your pump is normal, if you have an impaired relax phase, you're not going to fill with enough blood. You'll pump out the next heartbeat normal, but you won't have the same amount of fluid in that heartbeat or the amount of blood. So that's why it's as big a cause, as common a cause of heart failure, this type of heart failure. And this is the predominant type that amyloid is associated with. So to talk about the electrical complications, it's almost its own, electrical manifestations, it's almost its own manifestation of cardiology. I sort of refer patients for pacemakers and devices to a same colleague of mine now, Dr. John Keeney, because I think it's very good for the one person to build up that sort of expertise. We know, as I said, that atrial fibrillation, irregular heartbeat, is very common, and I'm going to show a picture in a minute of a typical atrium in a patient with wild-type amyloidosis. Atrial fibrillation is, again, a common condition, whether it's amyloid, whether related to blood pressure, whether related to other medical illnesses. One of the biggest things we worry about with an irregular heartbeat is risk of stroke. So you will see, just in case anyone has any questions, well, I came in for an irregular heartbeat and now I'm on a blood thinner. It really is one of the most important things about making a diagnosis of AFib, especially and including in a patient with amyloidosis, is making sure that we thin the blood adequately. And that's because, I'll just go ahead and show the picture, but this is an example of, these are very pretty pictures that our electrics cardiologists get when they're going in and they're doing an ablation and they're mapping out the left atrium. This is the top chamber, this left atrium chamber of the heart. And very nice, pretty colours. The pink, if I get this right, and somebody can't contradict me, but no, the pink is the good, normal tissue, healthy tissue in the atrium. The green areas, the red areas, the yellow areas are all amyloid infiltrated in the atrium. So you see how much or how extensive the infiltration of amyloid is, and it can be very difficult to, and this disease infiltration in the atrium, that's what predisposes to the irregular heartbeat. And so it can be very difficult to get rid of the irregular heartbeat. So the main thing is to control the heart rate with medications, but most importantly, to control the risk of stroke, and that's where the blood thinners come in, and that's why we'll really be focusing on blood thinning in patients with atrial fibrillation. Cardiac conduction system disease, as I talked about, every clinic and even intermittently in between, I think we need to find a better way of monitoring for slow heartbeat, because, we do ECGs on the day in clinic. I ask you to get what's called Holter monitors, where you'll be wearing a monitor 24 to 48 hours, and that's monitoring all your heartbeats over the whole day and seeing are you running into slow periods or too slow periods or a tendency to slow periods where you might benefit from having a pacemaker. And I think we may need to think about other more modern techniques of maybe doing that from a patient perspective, or monitors that we can have at home, because it really is important not to miss, because again, it can actually worsen heart failure symptoms, and it can also present with, somebody can present with a blackout and injure themselves. So how might patients present clinically, knowing that sort of background? So this is a slide that I use to sort of go through with our fellow cardiologists, with GPs, with medical case conferences and non-specialists in TTR amyloidosis, to sort of highlight red flags. And I think there's patients are in clinics, in cardiac clinics already, or in general medical clinics already, or in GP surgeries, obviously, with a combination of these factors, which individually are all quite common and expected for a person's age group. But when you really need to combine and think of them together. We'll go through some ECG patterns, but again, as we've heard great talks on peripheral or autonomic neuropathy or postural hypertension without being a diabetic or having other conditions, having a pacemaker plus a thick heart plus neuropathy, obviously the bilateral carpal tunnel syndrome. There are a couple of other features as cardiologists as well that we need to think about if we're seeing a thick right side of the heart. So I'm going to show you some echo pictures, but amyloid, both types of wild type amyloid tends to affect both sides of the heart. So that's often a key sign that this is something that's not more common like blood pressure or a heart valve condition, that it's something different. And there are a couple of other cardiomyopathies that often, I get sent, is this a more unusual type of cardiomyopathy, and it's somebody in their mid-60s or early 70s, and it frequently turns out to be amyloid. So it's important that we have that index of suspicion. So how might a person come? Again, I'm using that heart failure in inverted commas, heart inefficiency. It often has what we call, people often present with a predominantly right-sided presentation. What does that mean? That means more swelling. So ascites is abdominal swelling, leg swelling, elevated neck veins. People will see me coming towards their necks, just so you know, I'm looking for extra fluid in the system, and that's a sign of decompensated heart failure. Orthostasis, Sinead did a really nice presentation on how to check blood pressure lying and standing and when on presentation in our regular clinics. There's a couple of other features there, which some of them are consistent with AL, maybe presentation signs of AL as well as TTR. So we'll just skip through those. So what tests do we do to diagnose and to monitor it? So 12-lead ECG, this is an example of a normal ECG. If you see here, I won't go through the sort of the technical aspects, but there's a P wave, a small wave followed by a longer wave, which is your QRS wave. And when we do an ECG in clinic, we're looking for lots of different things. We're looking for the size of those sort of upward strokes or upward deflections. We're looking to make sure the P waves are there. We're looking to make sure there's no evidence of what we call blocks or slow heart rate. So this is a classic, what I would say is pretty classic cardiac amyloid ECG in a patient with quite established amyloid, and you can probably see that they look quite a bit different from the normal to the more established pictures. So those large upstrokes are mostly downward strokes. They're what we call pseudo-infarct or Q waves. And you see they're wider. That means there's an element of block there. And that's somebody that, if somebody had this ECG, I'd be looking quite closely to see whether or not they needed a pacemaker. So we're looking for AV conduction abnormalities, bundle branch block, pseudo-infarct pattern, and low voltage. Sort of technical terms. And of course, we're also looking for irregular heartbeats like atrial fibrillation, atrial flutter, and that's where you don't get that extensive P wave. So in terms of echo findings, I'm going to go through some pictures here. So classic echo of a patient with established cardiac amyloid, we're going to see quite thickened heart walls in all the different views of the echoes that we look at. If we show here, down on the bottom, this sort of bullseye picture is sort of a classic technique that I think most centres are now doing. We certainly do it on all patients in the Mater, and it's called strain. And you might hear me talking about, well, you know, your strain is preserved or your strain is mildly affected. And it's, without getting too technical, it's a really good measure that we have. And it's really good to monitor patients over time as well to see how they're getting on the various treatments. So again, increased wall thickness. We also see the valve leaflets. The valves are components of the heart that prevent that backflow of blood and make sure all the blood is moving forward. So again, in established amyloid, we can see thickening of all the valve leaflets. We all see, sorry, apologies, it's difficult without a pointer, but I'll move forward a little bit quicker. We can sometimes see what we call this characteristic myocardial speckle appearance and trivial or small amount of fluid also around the heart. There's a couple of classic signs that we also look for in the echo that I use this for teaching a lot in terms of our trainees. So really getting them to focus, getting them to identify earlier the classic signs. Or as I said, the right ventricle involvement is a key sign. The most common cause of thickening in the heart is blood pressure, high blood pressure, and high blood pressure is very common. It's common in people, you know, in older people also. So, but high blood pressure should never cause right-sided thickening. So that's a real key. You know, any of the GPs in the room or physicians or heart failure nurses, that's a really key thing. If you get, even if you're not an echo person or a cardiologist, you get a report back saying RVH or right-sided thickening. That's not just blood pressure. There's something else going on. So again, this classic strain picture that we talk about, it's called apical sparing or cherry on top, and it's really useful, especially if we don't have access to cardiac MRIs or for just making the diagnosis. It's a really useful technique to have. We talked briefly, cardiac MRI was mentioned this morning. I don't use MRI a lot for diagnosis. I don't think we need to use it for diagnosis, which is useful since a lot of times we don't have a huge amount of access to it, but I think it's really useful in the differential diagnosis. So if we're not sure, could this be other conditions, or if somebody has several different possibilities of what might be causing their heart disease. I think in the future it's going to be really, really exciting though for monitoring response to disease, and there's a couple of newer techniques that are available that hopefully will tell us more sort of microscopically, for want of a better word, inside the heart, how things are changing, are things stabilizing, are things improving after people have been on their treatment. So one of the questions we got a chance to look through was just what exactly is a DPD scan, and apologies, I probably call this too technical here. The DPD scan, when you come, we do them in the Mater, we do them in many centres. It's I suppose a simple bone scan. It's like coming for an X-ray. It's a little bit different because you get an IV line is put in. You come, you meet your technician, get the IV line, you get injected with we call it a tracer or an isotope. They use a different one in America to the one we use here. We call the one that we use here DPD. So DPD scan is a bone scan where you're injected with this substance. After 3 hours, you come back and you get a special type of X-ray and a special sort of CT nuclear medicine scan combined. And it's the combination of those scans. There's a certain pattern that tells us whether or not you have cardiac amyloidosis. And it's best used as a rule-in for TTR. So this is what's so good about it. In those, if we've ruled out AL amyloidosis with the blood tests and we have a good quality bone scan, DPD scan, then we can make the diagnosis, and that's without having to get heart biopsies, which we used to have to get, etc. There are a couple of false positives. We need to sort of be aware of those and use it wisely, but it really is a game changer. So if you're coming to the Mater for a DPD, then sort of block off that morning. But it's very well established and set up. This is an example of a grade 3 positive DPD scan, the combination of the X-ray type planar image on the left with the sort of SPECT CT image on the right, and the bright areas on the purple scan, so the sort of orangey areas, both in the left side and the right side of the heart, are examples of uptake that's consistent with TTR amyloidosis in somebody who has no abnormalities in their bloods suggestive of the AL type. So sort of a quick picture of how we diagnose it. Again, this is somebody coming to me with query cardiac amyloidosis. There's a clinical suspicion or heart failure syndrome, or as a family member affected. we're doing an ECG, we're doing the echo with that strain technique, plus or minus a CMRI, a cardiac MRI if I can't get the windows on echo or if I'm not sure. We rule out AL, hopefully, with the blood tests, and after that we can do our DPD scan, our bone scan, and rule in TTR if that's the case. After that, we need to go ahead and do our genetic testing and figure out if this is wild type or hereditary. If it is hereditary, what particular variant that we have. I think this is a nice slide which shows, again, sort of the theme of earlier diagnosis, which of the manifestations are what stage of disease that the different tests become positive in. So I think, as we've all heard, the orthopedic manifestations tend to come first, the bilateral carpal tunnel syndrome. Biceps tendon rupture, I was going to ask Julian if he's ever seen. I've never seen it. You've seen it? Yeah, I've never seen it physically. And Mark has seen it, okay. But as we said, lumbar spinal stenosis, they're sort of form thrust often of the condition that happen between 5, 7, 9 years, sometimes up to 13 years earlier. In terms of the test that we use for the heart, what's reassuring is, again, sorry, there's a lot of different names here, but the nuclear scintigraphy is, say, the DPD scan that I was talking about. That is positive or will demonstrate disease much earlier in the disease trajectory than things like echo or blood tests or patient having heart symptoms. So that's really good to know, again, in terms of trying to, get people in and diagnosed earlier. So how do we treat the heart manifestations? I'm not going to talk specifically about the disease-modifying therapies that Julian's going to talk about, but just to say, and hopefully to be positive, that there are a whole host of treatments for the heart manifestations, so that anybody who knows or who is themselves or who has someone in their life who has established heart disease, it's there's no need to be, there's a lot of treatments coming down the line, and it's a really, really exciting arena, as well as obviously the most exciting disease-modifying therapies. I think of the therapies, and especially in busy clinics, in terms of pillars and things that, and as I teach, fellows and trainees, pillars of things that we need to think about. We need to think about the disease-modifying therapies. Are we on the right treatment? Have we access to the treatment, which was mostly the problem? How do we get access to it? That's thankfully not less of a problem now. But then we also need to think pillar 2, the congestion management, the heart failure management, particularly when we have autonomic neuropathy and other difficulties and other conditions. Patients just don't have their amyloid condition. They often come with other conditions that we need to think about. Device therapies, that's where we're talking about pacemakers. Defibrillators are not really a device that is used frequently in this population on a standard level. The arrhythmia therapies is where we think about, well, how are we going to keep that heart rate settled down? How are we going to make sure that the heart rate isn't going to go too fast in the atrial fibrillation? And that's something that I think is evolving right now. Amyodrone or Cordrone is probably the best drug that we have. It's an anti-rhythm drug, but it's probably the best rate control drug that we have in amyloid patients, because often, and we'll talk a little bit about beta blockers, but beta blockers are great drugs for controlling the heart. They're standard medications, but again, they slow the heart down. So that's something that we have to avoid, slowing the heart down too much. And then anticoagulation means blood thinning. So blood thinning for any sign of atrial arrhythmia because of that risk of stroke. And thankfully, transplant is becoming less relevant for a number of reasons, both heart and liver transplant, because of these therapies. So we've heard a lot about diuretics. I need to come back the way now and say, I talk a lot about restricting fluids, and in the appropriate clinical setting for a standard patient with heart inefficiency, I ask them to think of it like a pump or like an engine, or to have the most efficient heart engine. Generally, we like to keep the volume of liquid in the day to 1.5 litres. So it's quite strict, sometimes between 1.5 and 2 litres, and that's to have the most efficient symptom. Certainly any more than 2 litres, and usually a patient with established heart dysfunction needs to be on a diuretic. But it's a balance, as we've heard, and it's actually interesting. I'm learning things. I would always tell patients to take their diuretics earlier in the morning. It's like coffee. Take your second diuretic before 2 or 3 o'clock, so that you're not awake at night. But maybe it might be less important to a patient to get up peeing at night and feel better during the next morning. So again, it's I'm learning as well how to ask patients and approach things. But it is a balance with the diuretic, because it's a stiff heart condition. We never want to go too low in the fluid level, but it's a condition where they're very predisposed to go too high quite quickly. And we have patients that do need to come into the hospital with sort of a decompensation with 2 kilos of, maybe just 1 to 2 kilos of fluid, which isn't a whole lot in terms of the grand scheme of things, and maybe in other patient conditions, but can mean quite a lot and can make a patient with amyloid quite sick and need to come into hospital. So it really is a tailored balance, and ideally patients are managed through local, again, terrible name, but local heart failure or heart dysfunction clinics. So, diuretics really need to be tailored. What might work for you this week might not work for you next week. So really having that sort of spoken hub and model, which we have with many of our heart failure units, including the Letterkenny unit who are here. So local heart failure clinics are really, really important. Just again, in terms of general medications, some of the classic teaching as I was coming up through was, never give a patient with amyloid beta blockers, never give ACE inhibitors, never give digoxin. We still don't give digoxin. But it was interesting to note, and I'm not talking too much about the ATTR trial. Julian will probably mention it, but it was the first randomized controlled trial for cardiac amyloid. And about 30% of the patients were on beta blockers and RAS inhibitors. And I think it's like a lot of things in medicine. There's never a role for never. And I think, and probably even more so, I know you won't be able to read this slide, but in sort of non-amyloid heart failure, we've lots of treatments that increase lifespan hugely and that keep people out of the hospital. And there are massive therapies. They include those ACE inhibitors and beta blockers type medication, spironolactone, which patients usually are on. But it's interesting that, why should we say they're not suitable for patients with amyloid until we test? And I think we're also maybe broadening the evidence, I think we're broadening the collaboration internationally as well to see, well, maybe we can test or not, trial these drugs, or they may be of benefit in this population. So it's really good to see things moving forward, because these are really, really important drugs in other types of heart failure. A brief word on the atrial fibrillation: always anticoagulate for GPs. You see any AFib at all. In other conditions, we wait for maybe 30 minutes or 4 hours. In amyloid, any AFib, then you want someone to be on a blood thinner. And we're awaiting guidelines specifically about further management. Take care of the other basics. I know we've heard a lot about autonomic neuropathy and blood pressure going low, but I will say, particularly in early stage patients, which thankfully there's a lot of patients now coming earlier stage, we still have to take care of the other cardiac basics, as I said, and high blood pressure is very, very common and very, very frequent. I feel like GPs think I'm obsessed about blood pressure, because every single letter I send back is, please get the blood pressure to, what I'm talking about here is too high blood pressure under control, because, and under control properly. Too high blood pressure is a major pressure loading condition and makes the heart stiff. So you don't want two hits and two things that are making the heart stiff. If you have risk factors for having coronary artery disease, then we need to look into that. That's, maybe you need, stents might still be needed, or cholesterol medications. Obviously, diabetes, if you have diabetes, needs to be treated. These are things we'll also look at the cardiac clinic. Minimize alcohol. It is a cardiotoxin, particularly if the ejection fraction or if there's any evidence of weak heart. But it also, if you're drinking your regular amount and you're drinking alcohol, it probably is going to be a fluid overload as well as a little bit toxic. So I usually say minimize it as much as possible for your quality of life. We heard also it causes peripheral vasodilation. Avoid smoking, the healthy diet and BMI. Exercise, if you can, both aerobic and resistant, is fantastic for preventing frailty that can come on with this disease as well. What happens? We're almost there at the amyloid clinic. So we'll ask about this, sort of the heart amyloid clinic. We'll ask about shortness of breath, swelling and fatigue, because we're looking for just tying it all together, sort of any cardiomyopathy or heart failure. I'll ask about what I call rhythm symptoms. Have you had any collapse, fainting, near faint, any palpitations? I'll usually ask about autonomic type symptoms as well, and we'll do the lying and standing blood pressure, any lightheadedness, because that affects some of the medications that I can prescribe and how I can prescribe them. We'll, if we have time, ask about other symptoms and health issues, but really focus on those three as well as the medications. We'll always examine your blood pressure, your heart rate, your oxygen levels, your weight. I'll come up close looking at your neck veins, looking for fluid, feel your pulse, listen to your heart and lungs, and look for extra fluid in the legs and the belly. We'll do blood tests. We haven't really talked about staging, but we'll do the heart failure blood test, or the NT-proBNP. Liver function, if you're on tafamidis, is important. Kidney function, very, very important, as we're monitoring both the cardiac and the general disease, and others depending on the situation. 12-lead ECG at every clinic, and echo and strain, if we can, every 6 to 12 months. And more frequent than that, the 24-hour Holter monitors. And I'm just getting it's very useful for me to collaborate with the local clinics and local cardiology centres and even local GPs to try and get the Holter monitoring, because we do want to do that a bit more frequently. And at the end, we'll summarise, confirm treatment plan and pathway, any medication changes and follow-up plans, which will likely include the local heart failure clinic as well, where their focus is really going to be on the fluid and volume. Mark talked about the working group report. I'm not as patient as Mark, so I've really been chomping at the bit to hear something back about this, because I really feel, I sort of wrote this in the article, I think it's in your packs, but I really feel like, it annoys me when we can't give the very best service to our patients, and I would really welcome that we're going to get hopefully a proper funded service to sort of work alongside NAC and sort of in a sisterly relationship, but maybe not be, for our patients to be as dependent in terms of travel and inconvenience, but obviously keep those research and education and social links open. So really looking forward to being able to provide a more bespoke and quality cardiac service. So I'll finish there. Thanks very much.